Actually, the retina people only know my name, and I know I'm actually learning retina. Thanks to all of you, and thank you so much.
No, everybody knows your name, Ragini, don't worry.
Lane sir, we are changing over, sir. Last words for this session.
Yes.
So would you like to say, Lane sir, would you like to say anything?
This Karobi conducted session very well. Everybody, Hadis Asnani, then I think also Unik and everybody, they were.
Dr. Murthy was conducting.
Yes,
with
Murthy was also Murthy was conducting. Malika, I was hearing Malika also. I think everybody, Somshila, really, I was hearing you. I think it was a very good session. And all the presenters were also good, and also the moderators and co-chairman, chairman were good. So I also the Karobi in the theory, in practical, and in the research and subject. So otherwise, I see Karoni some other place. So I'm really happy.
Sir, we have Dr. Anand. So we have Dr. Anand Rajendran also from Arvind and Dr.
Yes, Anand Rajendran is seen, Harish is seen. Everyone is seen. I think Virappan is seen. I think everybody was there, and I'm very happy for to hear them. Thank you very much.
Thank you so much.
Thank you, sir.
Bye-bye.
Bye. Bye-bye.
So over to the next session, which is on Uvea. And I would like to invite Dr. Somshila Murthy, Dr. Padma Malini, Dr. Ashwin Bafna, Dr. Lubhani, and Dr. Rohit. They are the panelists for this session. And, just a word of respite for you all is, although the program says your session ends at 1:15, there is a lot of buffer time after that. You can carry on till 1:30. We'll have lunch after that. So you can go easy with this one. Although, as protocol, we should stick to the time, but you can definitely go easier, have a good, fruitful discussion. So please go ahead and start.
Pritam, please announce the mini concert.
Yes, and yes, we have to finish by 1:30 because we all have to go to Kansky Hall for the mini concert. This is one thing you can't miss. After I saw it on the first Sunday, I didn't miss it last Sunday, and today my seat is ready for that.
Good.
Please start.
Thank you very much. Wonderful to see all our colleagues from the previous session staying on. So I was actually waiting for Rohit, but Rohit, you're there?
Yeah, ma'am. I have joined in. Yeah. Can you hear me?
Yes, we can hear you.
Yeah. My bandwidth is a bit low today, so I'm keeping my video off.
Okay.
Yeah. Ma'am, so I would like to invite our panelist, Chairman Dr. Somshila Murthy. She's the head of Cornea and Anterior Segment Service, the Cornea Institute, Consultant Uveitis Services, and Consultant Cataract and Refractive Services at L.V. Prasad Eye Institute, Kalam NG Reddy Campus, Hyderabad. And our main areas of focus is cornea and inflammation. Our co-chairman is Dr. Padmanali Mahendradas. She heads the Uveitis and Ocular Immunology Services at the prestigious Narayan Netralaya, Bengaluru. She is the member of International Uveitis Society Study Group, and she is also the treasurer of Society of Inflammation and Research. Our convener for today is Dr. Ashwin Bafna. He's a practicing retina specialist in Mumbai. He runs 3 centers in Mumbai, one at Kemps Corner, Mira Road, and Bhiwandi. He is an honorary retinal specialist at JJ Group of Hospitals. And our co-convener for today is Dr. Lubhani Jain. She is a vitreoretina and a uveitis consultant at the Bombay City Eye Institute and Research Center. Over to you, ma'am.
Thank you very much, Rohit. It's wonderful to be part of BOA MOS Summer Focus and also to be heading the Uvea session, to be starting the Uvea session. So we'll start with one of our most bright, young, and illuminous faculty, Dr. Padma Malini Mahendradas. Padma Malini, of course, we have known each other for years, and already she's been introduced. Apart from what you have mentioned about her, it needs to be said that she's a very passionate teacher. She has taken many residents through their training and has contributed a lot in academics also. So Dr. Padma Malini is going to speak on viral and post-viral uveitis. It's a very interesting topic. She has a lot of research on it. All over to you, Padma.
Thank you, Dr. Somshila. afternoon to all of you. At the outset, I would like to thank BOE MOS for giving me an opportunity to speak on viral and post-viral uveitis. The viral uveitis is commonly caused by human herpes viruses, human immunodeficiency viruses, arboviruses, and influenza, Ebola, Zika, and SARS-CoV-2. Among this, what we face commonly is herpetic uveitis. Arboviruses causes post-fever retinitis. The need for an hour is SARS-CoV-2 with various manifestations. Let's see. The viral uveitis are mostly diagnosed based on the clinical presentation. The molecular diagnostics such as RT-PCR or a nested PCR help us to confirm the diagnosis. Certain diseases we do depend on serological diagnosis. If we are not able to find out, if we have a facility to access, the next generation sequencing can be used to find out the exact virus in the given case. Next, we'll move on to viral anterior uveitis. Viral anterior uveitis is diagnosed based on characteristic presentations such as pigmented keratic precipitates. They can have diffuse, fine, stellate keratic precipitates or atrophic patches on the iris. And these patients are managed with topical steroid cycloplegic and oral acyclovir. Now we'll move on to what are the things. Recently, standardization of uveitis nomenclature, some working group as classification criteria for herpes virus anterior uveitis have been published in April issue of AJO. According to that, the diagnostic criteria for HSV anterior uveitis is unilateral anterior uveitis associated with either positive aqueous PCR for HSV virus, sectoral iris atrophy in a patient who is less than 50 years of age, or HSV keratitis. If one of these features is there, then we can diagnose HSV anterior uveitis. These patients are managed with systemic acyclovir 400 mg 5 times a day. The duration, depending upon the disease, usually we give it for 4 weeks, then the tapering starts, or depending upon the presentation and the severity of the inflammation, the duration of the therapy varies from patient to patient. The next comes the varicella zoster virus anterior uveitis. Here again, as per the Sun revised criteria for VZV, it is unilateral anterior uveitis. The PCR helps us to confirm the presence of varicella zoster virus. Here we have large sectoral iris atrophy in a patient who's more than 60 years of age, or concurrent or recurrent dermatomal herpes zoster. These are the criteria to diagnose varicella zoster virus anterior uveitis. In acute cases, we put the patient on 800 mg of acyclovir 5 times a day for about 10 days. Then either maintenance therapy twice a day, or depending upon the inflammations, the duration of antiviral therapy varies. The next comes the CMV anterior uveitis is most challenging. And most often, earlier it has been described as nodular endothelial deposits or coin-shaped deposits. Here, as per the revised criteria, it is unilateral anterior uveitis. We make the diagnosis based on the PCR assay for the CMV virus. And they have done the AI model and they validated the observations, and they found out that no clinical features reliably diagnose CMV anterior uveitis. So based on this, based on the clinical presentations, we cannot confirm or make the diagnosis of CMV anterior uveitis. The PCR assay is a must to make the diagnosis in this entity. Here is a case example of a 58-year male who had CMV anterior uveitis. Here, the patient was put on topical canciclovir gel and topical steroids, where you can see the infiltrative as well as globular pattern of keratic precipitates. In addition to the clinical response and the assay, we use confocal microscopy as a tool to monitor the disease course. After 8 weeks, when we repeated, there the presence of keratic precipitates is also there, and the persistence of KPs on confocal microscopy shows the presence of activity. At this point of time, we added the patient or oral valganciclovir, and subsequently, after 4 weeks, we could see the resolution of the inflammations and disappearance of the keratic precipitates. So this can be used as an indirect measure to titrate the treatment. So in vivo confocal microscopy have a characteristic pattern for viral uveitis. The infiltrative pattern are seen in herpetic group of viruses which were published in ophthalmology. The outline pattern has been described by Shirashi et al. In case of CMV uveitis, which we don't see in our patients. Next, we'll move on to posterior uveitis. In this, the viral retinitis. Here, based on the morphological pattern, we can make the diagnosis. The Swiss cheese pattern is seen in ARN. There is cracked mud in a case of progressive outer retinal necrosis or a pawn. The pizza pie appearance or a tomato ketchup in a case of CMV retinitis. These three, based on the morphological pattern itself, we can make the diagnosis. Acute retinal necrosis occurs in immunocompetent individuals. Most often is unilateral, significant vitreous inflammation, focal well-demarcated retinal necrosis in the peripheral retina of the circumferential progression with occlusive vasculopathy. Next comes the progressive outer retinal necrosis. It occurs in an immunodeficient individual. Bilateral fulgurant necrotizing retinitis starts in the posterior pole. It's rapidly progressing. Most of the times it's resistant to antiviral therapy. Next comes cytomegalovirus retinitis, where we have pizza pie retinopathy, along with frosted branch angiitis in this case. Other type is a granular form of CMV retinitis. In addition to the clinical, molecular diagnostics and serological titer can be used to confirm the diagnosis of CMV infection. What are the drugs used in the treatment of CMV retinitis? The commonly what we use is the valganciclovir now. In addition to that, the other drugs are also there. There is a recent drug, the newer drug, that is Liturmovir, 480 milligram per day, can be used in the management of CMV uveitis, which has been published in Ocular Immunology and Inflammation. The next, we'll move on to post-fever retinitis. Most of the times, the patient will give history of fever. They may be saying presumed diagnosis either could be viral, but they will not have confirmed diagnosis on their hand. 2 to 8 weeks, anytime later, the patient presents with blurring of the vision. Most entities, they have retinitis, retinal hemorrhages, with or without macular edema. This post-fever retinitis is commonly caused by arboviral infection. This is chikungunya, dengue, and West Nile virus. West Nile virus, the lesions can be distributed along the nerve fiber layer of the retina. That is not the case in all the cases. The next is Ebola and Zika virus can have chorioretinal scar, the presentation. The next is the most current pandemic is caused by the SARS coronavirus. So we'll see what are the manifestations. The first is 26-year male presented with history of dengue fever. Subsequently, you could see the bilateral retinitis secondary to dengue infections. You can see the retinitis and retinal hemorrhages with the macular involvement. FFA shows early hypo with late hyperfluorescence with dysplee in both eyes. OCT shows hyperreflective dots with hyperreflectivity with after shadowing, associated foveal involvement. Following systemic steroid therapy, we could see the resolving retinitis in this case. Here is a case of a chikungunya retinitis started at the posterior pole. Serological titer for chikungunya was positive. FFA shows early hypo with late hyperfluorescence. OCT shows hyperreflectivity with after shadowing with SRF. Following treatment with steroids, we could see the resolution of the retinitis with thinning of the nerve fiber layer retina. The next, we will move on to COVID-19 and uveitis. This is a need for an hour. It has like varied manifestations: anterior uveitis, bilateral pan uveitis with neuroretinitis, acute macular neuroretinopathy, what we call it as AMN, various retinal vascular occlusions with uveitis component, and Sapiginous choroiditis presentations following COVID, and various endogenous endophthalmitis could be due to bacterial and fungal infections have been reported as an ocular manifestations following COVID-19 infection. In the pediatric age group, the multi-inflammatory syndrome complex have been reported. As the disease course progresses, we are going to see more and more younger people, and including the pediatric age group is going to get affected with this. In this, basically, have bilateral uveitis. The clinical picture have associated cervical lymph node and throat involvement. The picture is something like Kawasaki disease. Elevated COVID antibody was noticed, and this patient was immunoglobulin and oral steroids. following which the good improvement in the vision. In addition to the uveitis, the recent studies reveals the presence of conjunctival isolation of the COVID-19 virus in the conjunctival secretions from the tears and also from the vitreous fluid have been reported. We are seeing more of vascular occlusions in association with hypercoagulable state associated with COVID-19 infection, such as CRAO, ophthalmic eruptions have been reported, and papilloplubitis also in a case following 6 weeks post-COVID have been reported in the literature. Here we would like to share our case, a post-COVID-19 ophthalmic manifestation in an Asian Indian male, which we have reported in ocular immunology and inflammation. In this patient had bilateral panuveitis with central retinal artery occlusions in the right eye. This is again due to the hypercoagulable state. So it's important, in most of the patients may not present during the infective stage, they present in the post recovery phase. This particular patient presented with us 3 days following discharge from the hospital. So anytime they present due to vascular occlusions or uveitis due to the hyperinflammatory and hypercoagulable state in COVID-19 infections. So coming to COVID-19 and uveitis, we can see the patients either in the infective stage. In this stage, RT-PCR is positive, then antiviral therapy has a role. In the inflammatory hypercoagulable state, we treat them with corticosteroids and anticoagulants or blood thinners. In the late phase, associated diabetes and strong steroids and tocilizumab and other immunosuppressive therapy, they'll end up with secondary infections, could be bacterial and fungal. We did see quite a few cases of candidiasis in the first wave, but in the second wave, we are seeing a lot more mucormycosis. That is predominantly an orbital involvement than uveitis. This is an algorithm approach for a suspected case of viral retinitis. We need to ask whether the patient had a fever, skin rash, or joint pain, and we need to rule out any associated systemic involvement like hypertension, systemic lupus erythematosus, syphilis, or toxo, or HIV. Then we check if it's a sporadic case, ARN, PBORN, and CMV. Based on the molecular diagnostics, we start the patient on appropriate antiviral therapy. In an epidemic case, we see chikungunya, dengue, West Nile. In novel cases, Zika, Ebola, and H1N1 have been reported. We diagnosed it based on the serological or by the serological or by the molecular diagnostic test, and we do treat these patients with oral steroids with plus or minus doxycycline. Now, the pandemic is caused by the SARS coronavirus 2 virus. Here we see, depending upon the ocular manifestations, we decide the treatment either with topical or systemic steroids plus or minus anticoagulants if it's associated with vascular occlusions. Whenever we see a patient with viral uveitis or a viral retinitis, there are certain things which we need to do. Viral retinitis, it's most often it's considered an ophthalmic emergency. The virus eats away the retina. We need to start the patient on antiviral therapy based on the clinical diagnosis. Molecular diagnostics help us to confirm and also the quantify the amount of organisms. Antiviral therapy is important, appropriate, adequate therapy to be started. In case of intravitreal antiviral therapy, such as ganciclovir, can be used in case of CMV retinitis. Most of the times, we need to continue the antiviral therapy, especially in a case of ARN, we need to continue for about 12 to 14 weeks in spite of the healing of the retinitis to protect the other eye. This is coming to the don'ts. Systemic steroids should not be started without establishing the exact etiology. We do treat arboviral retinitis cases with systemic steroids, but it's important that we rule out herpetic and other infective causes of retinitis before we start this patient on systemic steroids. To conclude, viral uveitis is mostly caused by the infectious phase, or posterior uveitis could be due to the immune mediated. It depends upon what stage in which the patient present to us. The dilated fundus examination is important, especially to diagnose acute retinal necrosis. Otherwise, we end up missing this finding. The next is we need to tailor make the laboratory list of investigations. Molecular diagnostics tests such as PCR plays an important role in the diagnosis of viral infection. The COVID-19 manifestations are very challenging and they have varied presentations. So high index of suspicion is important to recognize this entity. Aggressive and appropriate therapy can help to preserve the good vision in these patients. Thank you for your attention.
Thank you very much, Padma, for such a comprehensive talk on viral uveitis in general, and very interesting to see the cases of COVID-19 related uveitis and other inflammatory manifestations in these patients. And I also see that you have some publications on them, so congratulations for that. So I'm not sure, but since slightly we've gone over time, maybe we'll take the questions towards the end. And I think Dr. Soumya Basu is going to join in a bit late. So I'll ask Rohit to sort of get ahead of the line. And Rohit, as most of you from Mumbai are very much aware, Rohit is your dynamic young ex-BOA secretary. And he's also practicing retina surgeon and also sees uvea and inflammation from Mumbai. And he's presently working as a consultant at Centra Clinic and Hospital. And Rohit is going to talk about diet and how it can make a difference in controlling inflammation. All yours, Rohit. I'm all yours, by the way.
Thank you, ma'am. Is my slide visible?
Yes, it is.
Yeah, thank you. So I will be speaking on how diet can make a difference in controlling inflammation. I am not a dietitian, and I'm still exploring the world of nutrition, and there is no financial interest. So let me start with the concept of whole food plant-based diet. This diet focuses basically on plant-based food products. So hence we need to eliminate all the animal products, which includes meat, poultry, and dairy, and elimination of processed foods, such as bakery, farsan, namkeen, packed foods. And the focus in this diet is mostly on consuming plant-based diet, a good proportion of raw salads. Another concept is which is similar to what I have discussed before, is of a power plate from Physicians Committee for Responsible Medicine, is that if we have an equal quantity of fruits, vegetables, grains, and legumes, our nutrition is taken care of. Only addition would be required is vitamin B12 and D3. So initially I came across this paper, which I really found interesting, was that, plant-based diet was used as a monotherapy in psoriasis, and there was a complete reversal of disease. Now, this is based on the concept of a nutritarian diet by Dr. Joel Fuhrman, in which he insists that our diet should consist of a mixture of these things, such as greens, that is green leafy vegetables and other vegetables. Beans would include all legumes, and onions, mushrooms, berries and other kind of fruits, and seeds and nuts, and also whole grains. Once we have a diet which consists of these things, we are able to reverse chronic illnesses. Another beautiful concept is of hypernourishment by Dr. Brooke Gorler. She herself was suffering from lupus, which got reversed on a whole food plant-based diet. Especially she was she was trying to lose weight before marriage, and that's why she started consuming a lot of green smoothies, and she saw that her tests started getting negative, inflammation started going down, and that's where she studied a bit more into the concept of raw salads and consume combination of green smoothie and grounded flaxseed combination for reversal of autoimmune conditions. She has published a couple of books and a lot of case series on different autoimmune conditions. Now let's understand how does it happen. Let us look at one of the important intermediary in the inflammatory pathway, that is arachidonic acid, and it is mostly found in animal products. In fact, exclusively found in animal products, whether it is dairy or meat or poultry industry. Now, basically, the membrane phospholipids gets broken down into arachidonic acid, which ultimately leads to inflammatory mediators leading to inflammation. Now, if we increase the consumption of omega-3 fatty acids. Now, this has been quite a big thing. Our reps come to us that these antioxidant capsules also contain omega-3, or there are reps which come with exclusive omega-3 supplements. These omega-3 basically supply alpha-linoleic acid, which ultimately gets converted into anti-inflammatory mediators PGE3 and LTB5. Here, one of the rate-limiting enzymes is delta C6 desaturase. So when we eliminate the animal products, vegetable oils, and processed foods, the omega-6 pathway, that is the inflammatory pathways, intermediaries are not there. And there is exclusive supply of alpha-linoleic acid. And hence, the whole of delta-6 desaturase is available for the anti-inflammatory pathway, which in turn inhibits the inflammatory pathway. And that's why a reversal can occur in inflammation, in chronic inflammatory states. Now, this has been studied extensively in rheumatoid arthritis, where they had shown that the symptoms and the inflammatory markers in rheumatoid arthritis had decreased significantly. And initially, it was attributed that weight loss could be one of the reasons why the inflammation was going down. But they found out that a low glycemic, high fiber, low protein diet could mediate inflammation by decreasing pro-inflammatory gene expression. And it improves insulin sensitivity even after reductions in inflammatory markers due to weight loss are considered. So even if we take out the confounding factor of weight loss, this diet was found to have anti-inflammatory action. Another concept is of gut microbiome. Now, when a diet which is deficient in dietary fiber, now because of our urban lifestyle and consumption of dairy and meat has increased, of processed food has increased, the fiber content of a food has decreased. Now, a fiber poor diet or a fiber free diet, hampers the barrier, and it causes barrier dysfunction in the intestinal mucosa. And this can lead to translocation of gut pathobiome, which drives the autoimmunity. So this translocation can be reduced or prevented or reversed if a fiber-rich diet is taken. And by the term fiber-rich diet would mean that increase in consumption of legumes, in green leafy vegetables, grounded flax seeds. These are good sources of fiber. There is a concept, this low-fat vegan diet has been proven quite effective in reversing completely or partially type 2 diabetes. And we know that in type 2 diabetes also there is chronic inflammation. And when it was compared with a diet which was this diet recommended by this American Diabetic Association, there was a greater reduction in weight, greater reduction in glycosylated hemoglobin, and more patients had to cut down medications, and there was also greater reduction in the total cholesterol. So let's understand the hypernourishment protocol, what is recommended by Dr. Brooke Goldman. One of the key things she recommends is a green smoothie, where she asks us to blend green leafy vegetables such as spinach, kale, or spring onion leaves with mint coriander. So in this, what happens is the green leafy vegetables are the most nutrient-dense vegetables. Their cell walls gets broken when we are blending them, and when we mix it with grounded flax seeds gives the unprocessed oil and helps in absorption of fat-soluble carotenoids and other fat-soluble vitamins. Avla is a very good source of antioxidants. One of the highest contents of antioxidants is there in avla. And we can add a fruit for flavor. And obviously, we should not strain the smoothie. People who were kept on the hypernourishment protocol were asked to take 90% of the meals or 80% of the meals as green smoothie, which also helped them to increase their water intake and has shown significantly to reverse certain autoimmune conditions. Another important concept is to understand the role of sulforaphanes. Now, sulforaphanes are basically, anti-inflammatory in nature. It reduces the oxidative stress via phosphorylation and accumulation of nucleofactor E2. It is also having anti-cancer, anti-aging, and neuroprotective activity. A lot of pharmaceutical companies are trying to extract sulforaphane and make it into a product. Our recommendation is that why not have it from the natural source along with the other antioxidants and carotenoids such as the green leafy vegetables. In conclusion, whole food plant-based diet has an anti-inflammatory effect, which has been proven in systemic autoimmune conditions. The effect in treating uveitis is still not proven, though I have seen significant differences in my patients with diabetic retinopathy. In uveitis, it's still early to comment. More data is obviously required, but I do believe that it can act as an adjunct tool, and there may be cases where customization may help. Acknowledgements to my mentor, Dr. Soumya Basu, Dr. Anand Kumta, who introduced me to the concept, and the people who are leaders in this field, such as Dr. Michael Greger, Joel Furman, Brooke Goldner, Brenda Davis, Dr. Pramod Tripathi, and Madhura Vahar. Thank you. And thank you, BOA and MOS, for this wonderful opportunity.
Thank you, Dr. Rohit, for highlighting the plant-based diet and its advantages. Yeah, to share it with you, I'm also following the plant-based diet for nearly 18 months. It is very effective, especially in reducing the allergic tendency. Yeah, thank you. We will have the discussion later. Now I invite the next speaker, Dr. Kalpana Babamurthy, who's a consultant in Prabha Eye Clinic and Research Center, Bangalore, to speak on spectrum of uveitis in India, the clinical trend. Over to Dr. Kalpana.
Thank you. I'm unable to share the, just a second. I'm unable to share. If somebody can help, I think.
Can you see the share screen button?
Yeah, but it.
Yeah, it's coming now.
It's there.
It's there? Okay.
Yes,
okay.
It's ma'am, it's there, yes. Hi, Subhashila. Good afternoon, Padma Malini, ma'am. Good afternoon.
Hi, good afternoon, Dr. Ragini.
Okay, can you see my slides now?
Yes.
Yeah, okay. At the outset, I would like to thank Bombay Ophthalmic Society and Maharashtra Society for having me in this meeting. In the next 8 minutes, what I would be doing is to look at the spectrum of uveitis before 2010 and after 2010, look at the changing patterns, the probable factors which have led to this changing patterns, newer uveitic entities, and what is the approach we now follow in treating our patients with uveitis. Now, prior to 2010, uveitis was a very niche area in ophthalmology with very few uveitis specialists, and uveitis care was restricted to tertiary referral centers. So when we look at the literature, we have only 4 studies, 2 from South India, 1 from Northern India, and 1 from Eastern India for the pattern of uveitis. And consistently across all the 4 studies, anterior uveitis was the most common type of uveitis. And in more than 50% of the cases, they were not able to identify the etiology. When we look at the infectious uveitis, toxoplasmosis was the most common type of infectious uveitis, along with tuberculosis and leptospirosis, and VKH was the most common type of non-infectious uveitis. Now, this is just a composite figure showing the types of infectious uveitis seen in our subcontinent. Again, when we look at non-infectious uveitis, I just want to highlight this, which I will come subsequently. VKH was the most common then, and Sapiginous choroiditis was placed in the non-infectious group and treated with immune suppression. This is another composite figure showing the various type of non-infectious uveitis which is present in our part of the world. Now, post-2010, if you see the literature, we have increasing number of studies from almost every part of India. So now we have 2 studies from the north, one from the south, one from central India, one from eastern India, and one from western India. So what it shows is we are having more and more number of people treating uveitis, and it is no longer restricted to tertiary referral centers. Now, consistently across all these studies as well, anterior uveitis is the most common type of uveitis. And what is very interesting is now in more than 50% of the cases, we are able to identify the etiology, and this is consistent across all the studies. When we look at the infectious uveitis, if you see, tuberculosis is now the most common type of infectious uveitis, and this is again consistent across all the studies. And when you look at the non-infectious group, it is the HLA-B27. So different studies at varying timelines have shown that there is definitely a changing pattern. Now, when you look at the literature, we are seeing, especially in the infectious uveitis group, we are seeing that the prevalence of ocular TB has increased significantly. There is an increasing trend of viral uveitis. On the contrary, we are seeing a declining trend in toxoplasmosis, declining trend in CMV retinitis. And in the non-infectious group, we are seeing an increase in HLA-B27 positivity, and we are seeing more and more cases of ocular sarcoidosis. So what is causing the change in pattern? One of the most important factors is we have been able to establish the etiology in more than 50% of our cases. And the reason being, thanks to the newer diagnostic technologies, which include ocular imaging techniques, which have helped us to identify the level of pathology and have helped us to identify the pathogenesis. PCR has played a very important role in infectious uveitis, especially viral and tuberculosis. We are moving more and more towards HRCT in our patients with uveitis, especially granulomatous uveitis. And thanks to the EBUS TBNA, we are now looking at a definite diagnosis to differentiate tuberculosis and sarcoidosis. In addition to the newer technologies, we are also having multicentric studies from the Indian subcontinent, especially the COT study, the noted one, and the sarcoidosis study from our subcontinent, which have paid a large extent in identifying these diseases. Overall, we have started to understand the disease better. Just to give some examples, when we look at this pattern, this is what we call as Sapiginous-like choroiditis. And if I had shown you, I have shown you the slide earlier where this was considered, many cases of Sapiginous-like choroiditis were considered as non-infectious in the past, and they were treated with immune suppression. Thanks to the COT study, now we have been able to identify that this clinical phenotype is associated with ocular TB in high TB endemic countries like ours. Similarly, Eales disease. Now this was thought to be idiopathic, but now it has been associated with tubercular etiology in high TB endemic world. Also, other studies have provided substantial contribution in terms of providing clinical markers to differentiate tubercular uveitis, and probably this is one of the reasons why TB is now becoming more common in our part of the world. Another disease which deserves mention is the sarcoidosis study, and this sarcoidosis was initially thought to be a disease of the developed world, but we are seeing increasing reports from our part of the world, especially in high TB endemic countries, which have led us to investigate the role of Mycobacterium tuberculosis in the pathogenesis of sarcoidosis. This is a figure showing the different manifestations of sarcoid, both anterior as well as posterior. The diagnostic marker study from, which is a multicentric study from India, have led us to identify certain diagnostic markers which have been useful in many cases to differentiate between ocular sarcoid and ocular tuberculosis. PCR, as I had mentioned earlier, has definitely played an important role in identifying CMV-related anterior uveitis. Another important factor has been the multidisciplinary approach. We have started cross-consultations with our colleagues in various departments of medicine, especially rheumatology, pulmonology, dermatology, and have used their expertise and newer diagnostics available in their respective fields, and we are working now as a team. One of the most important contributions is in JIA. So now we have every patient to most ophthalmologists to detect uveitis. So we seldom see complications like what we used to see in the past, like band keratopathy, occlusion pupillae, seclusion pupillae, glaucoma. We seldom see these kind of cases. Another important disease is Blau syndrome and early onset sarcoid. Earlier, this was very, very rare in India, but thanks to availability of genetic testing, we are seeing increasing reports of these conditions from our part of the world. Another important factor is the availability of newer drugs. We have gone a long way from steroids, immunosuppressives, and now targeted therapy in the form of biologics. Our low threshold for immune suppression have led us to control the inflammation better and hence a better prognosis in our patients with uveitis. We also have biosimilars as well as local steroid implants, which have reduced cost in treating these patients to a large extent. But on the flip side, we are seeing a lot more cases of drug-induced uveitis, which we never used to see in the past. Another important factor in the changing pattern is the role of our national disease control programs, and the noted being the AIDS control program. Now, the free availability of antiretroviral therapy, if you look at the NACO 2015 report, you can see that the number of new infections have gone down, the AIDS-related deaths have gone down, and probably this is the reason why there is a declining trend in the CMV retinitis following the free availability of antiretroviral therapy thanks to our control programs. Now, we are also seeing resurgence of old diseases such as syphilis, especially in non-HIV individuals. And like Dr. Padma mentioned, we are seeing epidemics of dengue, chikungunya, and West Nile virus. And we are seeing this pattern, what we call as the multifocal retinitis. And most of these diseases follow a similar pattern. And this has led us to coin the term post-fever retinitis in these cases. They are usually associated with a favorable prognosis unless associated with vascular occlusions. This is a case of dengue maculopathy, case of chikungunya retinitis, which has been highlighted earlier, and the West Nile virus retinitis. Unlike the CMV retinitis in HIV, which has gone down, we are starting to see CMV retinitis post-intravitreal steroid injections going up. And contrary to the treatment of in HIV, these cases are usually refractory to treatment, requiring more injections of ganciclovir. And these cases usually progress to neovascularization due to the associated vasculopathy and ischemia. Rickettsial retinitis is becoming increasingly common, especially in South India, and this is quite common in children. They can present like these hyperreflective lesions. This is a child, and they respond dramatically well with doxycycline. They can also be associated with vascular occlusions. Another disease which deserves mention is Lyme's disease, which was never considered a differential in India. This study shows an increased seroprevalence in certain areas of India, and people hailing from these areas, if they present with such symptoms like neuroretinitis, it is important to keep Lyme's retinitis or Lyme's disease as a differential, and they do well with doxycycline and cephalosporins. Dr. Padma has highlighted very well the current COVID scenario, and we are increasingly seeing reports on uveitis in COVID. But what I would also like to mention is, along with the vaccination, which is now becoming more and more popular, we are seeing reactivation of autoimmune uveitis, especially the HLA-B27 related uveitis. And also we are seeing new onset uveitis following vaccinations. Also, these are very few in number, and this has to be kept in mind as well. So what has been the real change? The change has been our approach. So uveitis has no longer a niche area in ophthalmology thanks to the efficient dissemination of information in the form of trainings, CME, study groups. This has increased the awareness of varying etiologies and presentations both in the infective and autoimmune spectra. We are seeing a rapid progress in technology, both in ophthalmology and other fields of medicine, both in diagnostics as well as therapeutics. And most importantly, utilizing a multidisciplinary approach in managing our patients with uveitis. So to conclude, spectrum of uveitis is changing in India thanks to global migration, improved diagnostics and therapeutics, and our multidisciplinary approach. And this has improved our uveitis care and better prognosis for our patients. This is a patient with JIA, and if you see, this was way earlier when I started to practice uveitis. And this is my current JIA. It's an absolutely clear eye. Thank you very much for your patient understanding.
Thank you, Kalpana. That was really interesting talk, and it's just amazing to see. And I totally agree with you that with the therapeutics that we have now, we could never have imagined these results, perhaps when we first started or when we were training. We'll again shift the questions later on once we finish with everybody's talks. So we move on to the next. May I invite Dr. Samyak Mulkutkar, who is going to speak on masquerades and overview. As you know, Samyak, he's from Mumbai and he's a uvea retina specialist at the Hinduja Hospital. Hi, Samyak.
Hello. Hi.
Please go ahead.
Thank you. Can you see my screen?
Yes.
All right. I would like to thank BOA and the scientific committee, BOA MOS, for giving me an opportunity. Well, let's start with this case. This is the right eye of a 16-year-old female who presented with gradual decrease in vision for about 20 days duration. She just had motions vision. You can see that there's retinal detachment, probably exudative retinal detachment. Probably opacification of the retina as well, multiple hemorrhages. We can't see the optic disc here. These are the photos of the left eye, similar presentation. Exudative retinal detachment. We can't see the vessels, they're quite obscured, and these hemorrhages. So this is a diagnostic dilemma. We don't know what this is, but this patient is a known case of leukemia, of ALL. She was doing fine post-chemotherapy. Post-chemotherapy at 4 weeks, her blood counts are normal. We spoke to the oncologist. He says she's stable, but since these are immune compromised states after chemotherapy, could it be a infectious etiology? Could it be CMV? Could it be fungal? So that is one part of the thought process. The other is she has retinal detachment. Is it exudative? Could it be inflammatory? A number of oncology drugs do have ocular side effects, or is it a rhegmatogenous retinal detachment? So how should we go ahead? Should we go ahead with a vitreous biopsy? Should we give a trial of intravitreal ganciclovir, or is this inflammatory and should we start steroids? So this was the diagnostic dilemma that we faced. If you look at it more clinically, more importantly, we don't see the optic disc. So this is probably optic disc infiltration. We couldn't find the rhegma. We couldn't find a break in the retina. So probably this is an exudative retinal detachment. Looked hard in the periphery, did an indirect, couldn't find any retinitis patches. So it didn't look like CMV retinitis. So we went ahead, did the MRI, and we found that these are bilaterally but mildly bulky optic nerves. So we thought this is not infective, this is not inflammatory, but it could be a masquerade, and went ahead with a CSF tap, which turned out to be positive for leukemic infiltration. So this was diagnosed as a relapse of acute leukemia, started on the protocols, NY2 protocol, asparginase, vincristine, anthracyclines, and methotrexate. In the subsequent weeks that followed, these are the photos of the right eye. You can see how the exudative retinal detachment has reduced, and you can see the evolution of the leopard spots over a period of time. This is the right eye, and these are the vessels which seem to be occluded over a period of time. You can see these changes happening over the next 5 weeks. So just on change of chemotherapy, you can see the right eye has progressed, and now this patient has about 6/9 vision, She restored vision in the right eye. She restored vision in the left eye. So this is a case of acute lymphocytic leukemia, and this is a case of relapse of the leukemia, where the leukemic cells, they spill over into the circulation and they infiltrate either the liver, the spleen, the CNS, or the eyes. Now these correlate with the CNS involvement. Any ocular infiltrates, they are the sign of decreased survival and may be the only sign of relapse at times. Masquerades essentially are malignant diseases which mimic intraocular or periocular inflammation. In the eyes, we see most importantly primary intraocular lymphoma, or we might ocular involvement of systemic lymphomas. The other diseases like systemic leukemias, choroidal melanomas, metastasis, retinoblastomas, or paraneoplastic syndromes may also present as masquerades. Now coming to primary intraocular lymphoma, which is a subset of the primary CNS lymphoma, is one of the most common masquerades that we see. They may have a CNS involvement or may not, or they can be either a concomitant or a subsequent CNS involvement. What is the relevance of this? If you find a primary intraocular lymphoma, then there is an 80% chance that the patient will be diagnosed with a CNS lymphoma in subsequent time. Or if there is a diagnosis of a primary CNS lymphoma, then there is a 20% chance that he or she may have a primary intraocular lymphoma. So that's the importance of the ophthalmologist seeing this patient first. What they may present as just vitritis, or they may have yellow creamy lesions, which is very deep to the retina. They may present with vasculitis without any cystoid macular edema. And these lesions, as you see in these photos, they respond very well to steroids. They may increase or decrease in size as you give steroids, and they may appear from one place to another, so they may migrate. So you need to have a high index of suspicion in these cases. One of the very classical features is the leopard spot pigmentation, that you see punctate, small, round, hypo or hypofluorescent window defects with the late staining of the RPE on the fluorescein angiogram. You may see signs of vasculitis, but without any cystoid macular edema. On the OCT, you may see these hyper-reflective subretinal deposits, or you may see the retina being infiltrated, either the outer retinal layers or even the massive full thickness infiltration of the retina, which was reported recently in oculoimmunology inflammation. On autofluorescence, you may see leopard spots, which are hypo or hyperautofluorescent. And in fact, there are a number of different varying patterns of autofluorescence that you can see. Now, as a differential diagnosis, one may think of it as an infectious etiology to begin with, like viral retinitis, toxoplasmosis, or syphilis, or they might have differential diagnosis which is non-infectious. So a lot of times multiple investigations are done and often inconclusive. These patients are often over-evaluated and move from one center to the other. Neuroimaging, the MRI is better over the CT. If you have a lumbar puncture which is positive, then yes, it avoids ocular biopsy. But then if there's a negative CSF, there's always a chance that if you see a lesion in the MRI, then you can have a stereotactic vein biopsy. Ocular biopsy or ocular, you have to go in, do a vitrectomy and remove the infiltrates from the subretinal space. But we should remember that we should stop steroids at least a couple of weeks before the biopsy, otherwise it can be negative. Only 40% of them may turn positive in the first vitreous sample or a subretinal sample. We have issues with negative biopsies or multiple biopsies happening, but not getting a positive report. On the ocular biopsy, most of them are B-cell lymphomas. Very rarely you have T cells. The important thing is the high interleukin 10 to interleukin 6 ratio, more than 1, and it has a fairly good accuracy in the primary intraocular lymphoma. more than 90% sensitivity and more than 90% specificity. And this was one of the posters that I saw in USI 2019. Now these ratios will be reversed in uveitis, so it does make sense to do these IL-10 to IL-6 ratios. Apart from that, PCR analysis, MYD88 mutations, and these things will increase the rate of diagnosis to close to 70%. Of course, these patients do require radiotherapy, chemotherapy, or a combination of these. Ocular chemotherapy can be given, which is about 0.4 milligrams of intravitreal methotrexate, and Frankel et al., if you see that article, has good 10-year results, remission in about 6.4 injections. Now these are the ocular, this is ocular, this is limited to the ocular inflammation. And if you look at what was published in Ocular Immunology and Inflammation in 2017, 12 patients over 10 years, only 2 of them had neurologic symptoms and presentation. And they were frequently misdiagnosed, most commonly as tuberculosis. In the first instance, you may not diagnose it, but as long as you may take 17 months, as has been published in this article. The difference was from the Western thing that we had a younger age of presentation, and the anterior segment inflammation was also present in some of these patients, which was not previously described. They have a poor prognosis, about 12 to 35 months. Ocular therapy from our side, well, it does improve the local tumor control, but it doesn't improve the overall survival. What it does is that if you diagnose a primary intraocular lymphoma, when the patient presents first to the ophthalmologist, then there is a survival advantage, even though it's a small, but 5 years over 3 years. So you can give a survival advantage over these patients. Now the key features is that the clinical picture does not match the lab results. Often at extremes of age, you find that the patient simply doesn't fit the clinical picture. They respond well to steroids initially, but then they come back again and again. And if you see this irregular RP affectation or leopard spots, then there's a high suspicion of lymphomas or masquerades. So these are rare diseases and very frequently misdiagnosed. The ocular and neurologic features may or may not overlap. Remember, they are not only sight-threatening, but they are life-threatening. You need to have a high index of suspicion and a close follow-up of all these patients. Thank you so much.
Thank you, Dr. Samyak, for the excellent presentation on masquerades. Most of the times we end up diagnosing late in the disease in masquerades, and it's definitely nicely highlighted the high index of suspicion for the early diagnosis of this disease. Thank you once again. Next, the next speaker, Dr. Dipankar Das, who's a uveitis consultant and also an ocular pathologist at Shankar Netralaya, Guwahati. I invite Dr. Dipankar Das to speak on nuances in ocular parasitic diseases. Over to Dr. Dipankar.
Yeah, thank you, Padma Mani. I'm unable to share the slide. Just
we can see. So can you see the share screen green button at the bottom? Dipankar?
Yeah, I've clicked it.
Okay. No, then what you can do is just unshare it again and close everything else and open your PowerPoint.
Stop share.
Stop share, yeah. And close everything else. Of course, don't close the Zoom meeting, close everything else. Yeah.
Close it?
No, so.
Yeah.
Okay. Yeah.
Yeah.
Excellent, yeah.
Okay. Is it seen?
Yeah, it is seen now.
Good afternoon, chairs and everyone. I like to acknowledge BOA and MOA for giving me this opportunity. I don't have any financial disclosure in this presentation. This is purely an academic one. Well, so different parasitic disease can have various manifestations. Okay, so you see this case, a young man with a redness and difficulty in vision, and when he was seen in slit lamp, there was a parasite sitting in the anterior chamber. And you can well appreciate the parasite in the dancing in the anterior chamber. Now, I crossed this to a surgeon who did a paracentesis, and the live one was sent to lab in a bottle containing normal saline. You can well appreciate the worm is still a live one. Now, in pathology, what we did, we took the worm in a petri dish along with saline and put it under the objective of a compound microscope. Okay. Now we see all the internal structures are being visible, including the surface striation, even the genital pores, etc., are visible in a transparent way. So this is, you can see those worms, all the structure that you see in live ways. Now you see in wet mount preparation, this was diagnosed as a diarrhea, and we published in a peer-reviewed journal of this case. Now in post-operative case, this was the patient got down and he improved his vision and relieved of the pain. Now this is again an interesting case of a vitreal and retinal worm. And this is a patient was a nurse by profession and was having a history of taking smoked fish. Okay, this sometimes transmit the parasites along with salads. Rohit in his presentation mentioned the green salads, but they should be properly washed and cleaned before being taken, because raw salad sometimes can transmit this sort of parasitic things. Now this schematic diagram of 3-port sparse plana vitrectomy, where vitrectomy was done to get into the parasites. This is an animation picture showing, and the core vitrectomy to remove the adjoining hemorrhages, and later a flute needle was introduced and the worm was brought out. Now you see this very interesting video of this worm in 3-port sparse plana vitrectomy. Okay, now this worm which was sitting near the optic disc, okay, and the course vitrectomy has been carried out in this, and you can see it through the pupillary aperture. Now you see the worm was located there, and it was partially within a pseudo capsule. This was a live worm. Now, on being disturbed by the vitrectomy, proof the worm was. This is the vitrectomy done to remove the hemorrhages. Okay, you see the worm is moving. Okay, now worm is moving and it is on being disturbed. So, and part of the worm you can see within the pseudo capsule. Now, what it did because this procedure was very fast, okay, and we are showing in a slow motion, this worm, because it was afraid of the procedures, and it was making a track, making a hole in the retina. So this is a dangerous situation which is moving. Okay, now this surgery was carried out by our medical director, now president, Dr. Harsha Bhattacharjee. So we meticulously dissecting the pseudo capsule and bringing the worm out with a flute needle. Now see, it's trying to grab it with the help of flute needle. Now this is a very meticulous procedure, dissecting of a pseudo capsule. And now the worm is sucked in a flute needle and brought live. Now, the post-operatively, the hemorrhage, etc., gone down, and the patient vision improved to 6.6 and 6. And in wet mount preparation, the head valve showing 4 rows of hooklets, and the surface changes and intestinal and other caudal ends where meticulous is seen. Professor Narsingh Rao in Rohini was gracious enough to help us to take the scanning electron microscopic picture, and thereafter it was published in Retina as a original article. Again, you see another worm. It is in the subconjunctival space. Okay, now this worm was brought out. This one was brought out. Similarly, it was seen live, and this is the wet mount preparation. And this is a thalasia worm, which can be presenting features. We have reported 3 cases of thalasia, one with a gravid baby thalasia in the single worm published in Indian Journal of Ophthalmology. Another live ancestor thalasia calipedia present as a lump to the lacrimal sac in a 42-year-old female. Now we see this is again a case of a worm being sitting, making a hole in the iris. Now you see that worm has been brought out live, and putting it directly under compound microscope, within 30 seconds, we can give the report that what worm we are dealing with. Now you'll see the head portion of this worm, which is very, very important. Okay, you see, this is the head portion showing 4 rows of hooklet. Immediately, this is nephostoma. Okay, this is a nephostoma spinigerium. Okay, was correct with all other characteristics. Now, wet mount preparation showed all these features of a nephostoma spinigerium, and these hooklets, etc., are being photographed in the high powers of the compound microscope. Apart from this worm, the cysts are very, very important. For example, this is the hydrid cyst retrieved from the orbital tissue. And what we have studied in nuances is that the pores in the cyst wall is very, very important because they help into movement of the solutes. Okay, and this is very, very important. Cysticercosis is very, very important for the neurologist as well as for us as ophthalmologists. This can be seen, and if you do a B-scan ultrasound, you see a cyst as well as the scolex here, and the scolex and cyst was removed in these cases, and this has been published in a peer-reviewed journal. Sometimes you get a full-blown cyst like this, and obviously, what is danger of intraocular cysticercosis is that if you only put antihelminthic medication, it can incite a endophthalmitis-like picture. Okay, see this picture of a cyst with an endophthalmitis-like picture. So there's a difference between an cysticercosis in the orbit and intraocular cysticercosis. Orbit, you can put anti-cysticercus medications such as thiabendazole or praziquantel and oral steroid, but you cannot put thiabendazole or praziquantel initially in ocular cysticercosis. Okay, you have to remove them in toto, then you have to put the medication for the other cysticercus lesion elsewhere in the body. They have a in neuroimaging, the coin-shaped lesion of neurocysticercosis can be picked up. Well, Kalpana showed in all our various pattern of uveitis, in 2 of the pattern of uveitis, where toxoplasmosis in Biswas et al. Study and our study at Northeast Indian population, we have found toxoplasmosis to be the foremost cause of posterior uveitis. This is a headlight in fog appearance of a toxoplasmosis. Now, when you see toxoplasmosis multifocal bilateral, always you have to rule out HIV infection. So in around 12 years time, we have seen 93 cases of toxoplasmosis, where 24 were active, 52 were congenital cases, and these cases were presented in various conferences. Now you see, this is a toxocaria where the history of pica and contact with puppies is there. unlike a toxoplasmosis where there's a history of cat in the can be there in the histories. Okay, now it can present with a posterior granuloma, it can present with a peripheral granuloma such as showing here, or it can present as a endophthalmitis. Now we don't put anti-emetic medication here, we put only steroid, and this is after the resolution of the active phase. What is important is the phenomenon of uveitis in some of the filarial one. If you target the because there is a bacterial colonization which happen on the parasites, particularly in the female genital tract, and if you target with the antibiotic, then it prevents the assisted reproduction and it can kill the worm. So there's a lot of role of antibiotics in uveitis in filarial worm. So this is by Dr. Ratinam, the algorithm. She has two CTM examination, indirect ophthalmoscopy, ultrasound by biomicroscope, ultrasonography, optical coherence tomography, particularly for DUSN, then ocular, obviously ocular examination, systemic examination, then isolation of the worm, molecular confirmation. What we added here is a direct live examination of parasite under microscope. Now from North India, from various parts of the country, we are able to getting information about parasitic infection. Ratinam et al. Has found trematode infection significantly in their population. Now in pattern of uveitis, what we had shown, what Kalpana has quoted in her presentation, parasitic uveitis were 0.68 in anterior uveitis and 3.2% in a pan-uveitis case in our series. And for in etiology, toxoplasmosis was leading the table, followed by toxocaras, cysticercosis, hydatid disease, dirophyridia, thalasia, nephostoma, and two cases of diffuse unilateral subaqueous neurotinitis. This is a comparative study from Ratinam et al. From South India, Singh et al. From North India, and our present studies. We have seen in total, when it concluded for 12 years, it was 161. What I showed is a 91 cases earlier was around 6 years of these studies, and total in 12 was 161 cases. Toxoplasmosis was total cases once. Toxoplasmosis was 93 cases. Toxocaris, which was seen significantly, 33 cases. Unlike other studies, and cysticercosis was 17 cases in our series, and also Ratinam et al. Showed 18 cases in their series. USN, we have seen 2 cases. So these are our publication for parasitic uveitis with the update in pathology of ocular parasitic disease in Indian Journal of Ophthalmology. Now, all these years, the live worm examination we are able to do, and this has come with a recent textbook of chapter Vitreoretinal Surgery Parasitic Disease, where it has been mentioned that direct examination helps in the live parasitic examination. In conclusion, parasitic disease of eye and causing uveitis is not that rare. Early diagnosis and management and awareness of parasitic uveitis is a must. Live imaging of the extracted parasite helps in rapid diagnosis and prompt treatment of the patient. I'd like to acknowledge Professor Sohidul Islam, who is the parasitologist in Veterinary College, and he is regularly teaching me different parasites. Professor Narsingh Rao, Ratinam Madam, my president of our institute, Dr. Harsha Bhattacharjee, earlier our co-pathologist, Dr. Panna Lekha, Dr. Sen Kalyan, Hemlata, and Rajesh. So thank you very much for your patient hearing.
Thank you so much, Dipankar. It is wonderful listening to you, such a comprehensive overview. For those who don't know, Dipankar has won a lot of awards, both for the scientific part as well as several awards for his work on parasitology in ocular specimens. So that is just wonderful listening to the entire gamut of these cases. Dipankar, thank you.
Thank you so much, Amash.
Yeah. So if there are any quick questions, Rohit, do you have any update for that?
Till now, there have not been any audience questions. Can we do the question answers in the end after all the talks?
Yes, sure. But before that, if any of our conveners Dr. Lubna Jain or Dr. Ashwin Bafna have a couple of comments or questions while we just have the next speaker come up. Lubhani and Ashwin, if you're there.
Yes, ma'am. That was a great presentation by all of the speakers. Really enjoyed listening to it. I had a question for Dr. Dibankar. What is the role of laser in suspected DUSN?
Yeah, that's an interesting question. If you see now, DUSN, if you see, these worms are not that too big, but sometimes this laser, if you see, can, if you see a live worm in DUSN, okay, either in Dirophylaria or a, say, ankylostoma, if you can clinically somehow say that because of the size and other thing, it's a live worm, then around the live worm, if you do a laser, okay, that will help to kill the worm itself. It will not help to migrate, the worm will not able to migrate and form the tract. Okay, that's the important thing. Now we have a very interesting case, multi-center case of a very big worm in the posterior pole, where Professor Jyotirmohan Biswas, my mentor, is there. From Disha Eye Hospital, Dr. Devdulal is there, who is also a faculty in this meeting. And Dr. Aditya is there. All of us is sent a case in IGO, where the CNVM has formed because of the dead worm. Okay, so there is a role of some sort of role maybe there in those situations. But remember one thing, if you see a live worm, maybe the track of the worm can be stopped by putting a laser around it.
Thank you.
Thank you.
We'll go to the next talk and then we'll take comments from Ashwin. So it's once again my pleasure to introduce the next speaker, very talented Dr. Shishir Narayan, and also my friend, who is the consultant of uveitis and ocular inflammation at Shroff Eye Center in New Delhi, has several years of experience having trained in UK, and he's going to talk today about retinal vasculitis and Behçet's disease. Over to you, Shishir. So nice to see you. Not yet.
Yeah, it's so wonderful to see everybody. Good afternoon. Can I share my screen?
Yes, please. Yeah, please.
Are you able to see my screen?
Yeah, it's just coming up. Yes, we are. Can go to full screen.
Okay. I want to stop my own video. Can you hear me?
Yes, we can hear you.
Yeah, because oops. So we need to go back again. So sorry. We need to. So sorry. I need. So sorry. So you're seeing the reverse first, and then I'll go in first gear.
But you always do something different, so.
Yep. So I hope my my connection stays good for next 8 to 10 minutes. If I'm overshooting time, Somshila, just tell me. We are approaching lunch. So I just want to share the way I approach retinal vasculitis, and more or less from a clinical point of view, because retinal vasculitis is a morphological diagnosis, and there could be a large etiology, a huge list of conditions that can cause retinal vasculitis as a manifestation, clinical manifestation. So I'd give you my clinical approach and some few tips maybe that might help you. So one broad thing is that retinal vasculitis is very different from systemic vasculitis. Systemic vasculitis histopathologically has got necrosis in the vessel wall because of the inflammation. While in retinal vasculitis, because of the difference in the histology of the blood vessel, there is no necrosis. So what you are seeing in retinal vasculitis is actually only an inflammation that is clinically seen as retinal vasculitis. I'll quickly go to our most common retinal vasculitis, which for years has been called idiopathic peripheral uveitis. And we all know that it's a common entity in the young male adult in India. And the path-breaking work from stalwarts like Professor Mot Gupta and the PGI group and Professor Rao, we now know that there is an element of tuberculosis that causes this retinal vasculitis. So I just share with you one patient who was actually a dentist, and Mantoux was positive, but he wanted to make an absolute diagnosis for tubercular etiology. And we did a vitrectomy and sent the specimen, and this is long back. This is not now, this is about 7-8 years back, and it came positive for Mycobacterium tuberculosis, and we were able to make a diagnosis. Now, the reason I'm saying that is not only to make a diagnosis. I want you to appreciate this angiogram. And this angiogram here of this patient after vitrectomy is showing you areas of blocked retinal vessels. So BRVO-like picture, peripheral CNP areas, while the posterior pole seems to be reasonably okay, except for this area over here. Another case where you have a branch retinal vein occlusion, and you can see here that this pattern is showing a lot of perfused areas over here and small NVE and confluent CNP areas coming here in the periphery. Now I want you to kind of visualize this picture because we are going to refer to it again. And then the laser has been done to areas of CNP so that the NVEs regress. And you can see in this patient that laser has been done to treat only those areas where there is CNP and the neovascularization is stable. Sarcoidosis, we know, is not a primary vasculitic entity. So systemic vasculitis does not exist in sarcoidosis. But retinal vasculitis exists in sarcoidosis in the form of extensive candle wax strippings that can be seen, and it is a very typical picture that you can have in sarcoidosis. Now I'll come to Behçet's disease, which I actually used to underdiagnose for many years, and that's why I want to share my own experience with Behçet's disease. So we all know that this is retinal vasculitis. Again, is very systemic retinal vasculitis in Behçet's disease is not as much an entity as the retinal vasculitis in these patients. But what is interesting is that there is an inflammation of the disc here. The entire vascular tree is inflamed. So this is a very old photograph that Dr. JB has given me, and it is a conventional photo that is showing inflammation of the entire retinal tissue. And you can see here both eyes of this patient has got a fern petal appearance of the entire retinal tree. And if you do the angiography, this is a very old photograph. All over, all quadrants, you see the inflammation. And you used to therefore get a pale disc and sclerosed vessel. Now I want to show you one patient who again was an uncle of a medical student at Aligarh Muslim University. And he had a phacoemulsification in the left eye and had a hypopion and was actually referred to me for endophthalmitis. So when we saw the fundus, we really didn't see so much of endophthalmitis as we started seeing sclerosed vessel. So we did an angiogram and there was some appearance of fern petal appearance. And the next day he said, "Doctor, I don't want any test done because wherever you put the needle, I had an inflammation and I went for the blood test. And from where they took out the blood, I had this reaction." So basically what he was probably saying was that there is dermal hypersensitivity and there's a clinical clue. And the other eye had a very hazy view because of the cataract. So we looked very carefully and you can see here completely sclerosed vessels all over, which can be appreciated very nicely on a larger photograph. One interesting thing with Behçet's disease is that when the retinal vasculitis is there, it may not give you a clue. This is an 8-year-old child who has this picture, which is absolutely looking a normal posterior pole. But when you do the angiogram, you see here a complete vascular tree is inflamed, there is CME, and there is a fern petal appearance, while the other eye has not yet got involved, luckily. So now I will show you a case that was Mantoux positive, quantiferon TB positive, and turned out to be HLA-B51 positive as well. And he was very depressed with the diagnosis of possible Behçet's disease. So that's his report that shows HLA-B51 is positive and 27 is negative. Look here at this picture. He has had a BRVO here. He has had a laser treatment over here when he presents to us, and then he developed vitreous hemorrhage. So he was put on adalimumab with a possible diagnosis of Behçet's disease. And again, he underwent a vitrectomy because of the non-resolving vitreous hemorrhage. And there was a possibility of getting a diagnosis for ruling out tuberculosis. So I sent the specimen to my alma mater, Professor H.N. Madhavan, and you see the PCR was positive. So this is what it is. He had this, and he had this picture in the inferior part from where the vitreous hemorrhage has been removed. And compare these two angiograms. Pattern recognition. This is so different from this. So here the vascular tree is totally uninvolved, and then there is an area of BRVO, and here is that 8-year-old child who has got no clinical signs, but he has got an inflamed retinal tree. And now you compare with the dentist who had a positive, and this is the boy who's had the vitrectomy done. And this picture is very similar. So you see the pattern of inflammation and retinal vasculitis helps you towards making a diagnosis. So I'll just tell you just one more case. So it's a 24-year-old young, healthy male from an industrial family, because we generally have people from lower socioeconomic strata, you know, with uveitis or retinal vasculitis. But here is a high strata society young boy, and his MAN2 was negative. All the investigations were negative except for a borderline ACE. And he had an inflamed disc and he had a choked disc. And this is what he presented with. When we did a CT scan, the lymph nodes were there, and EBUS done showed non-caseating granulomas. So here we were dealing with a patient who had sarcoidosis clinically, and he had an inflamed disc with papillitis. But that's not the important thing. After 3 doses of intravenous methylprednisolone, suddenly his intraocular pressure went up, and he did not want to give consent for immunosuppressive treatment. So we gave him the option of giving him straight away Exemptia or an anti-TNF immediately after 3 doses of IVMP. So this is an unconventional treatment, and patient agreed to get Folitrax only to cover up for the antibodies that would develop with Exemptia. We gave him a regimen of 9 injections, and you see what happened. After the first shot itself, the inflammation came down, and this is 4 months later when the methotrexate has been stopped, and this is 1 year later, and the patient has still been coming, and we've actually not given him anything after 6 injections of Exemptia and covering it up with methotrexate. So the point is that anti-TNF can have a dramatic steroid sparing effect. Like even with COVID, we are now seeing that you are giving tocilizumab, which we were so hesitant to give, but we know that they have a dramatic steroid sparing effect. And, you know, the little experience has made us to give anti-TNF where we want to avoid steroid even as early as 4th day of inflammation. So, you know, adalimumab we knew is successful in refractive patients, but giving it as a first change treatment to steroid is unconventional. So, you know, you look at the complete picture, an ultrawide field really helps you to connect with the peripheral CNP areas. It could have manifested as an NV or a CME, and, you know, the entire picture comes to you with the ultrawide field. So already masquerades have been discussed, but one masquerade which is very interesting is anemia. So if there is anemia, there is a reactive thrombocytosis, and this is a reflex because the megakaryocytes of the bone marrow, they are the common stem cell. So when the iron deficiency anemia is there, your bone marrow gets upregulated, but instead of producing RBCs, it keeps on producing platelets because of the iron deficiency anemia. And when you correct the hemoglobin levels over a period of 2 or 3 months, the entire venous stasis settle down, which looks clinically like retinal vasculitis. And, you know, when you do a literature search, you find iron deficiency anemia presenting as this is resulting from a plant-based diet. So, you know, when you're taking a plant-based diet, like we discussed earlier, you can actually develop iron deficiency anemia. So, you know, you want to balance out everything. So it has to be a balanced diet rather than being totally a vegan diet at times. So, you know, you want to rule out these masquerades, like this young girl who has got FEVR, which looks like retinal vasculitis. But when you look at the other picture, you know that it is not retinal vasculitis. So look at the entire picture, try to have a pattern recognition based on angiography. And once you know the etiology, then of course, we are good enough to manage these cases along with a rheumatologist. Thank you so much for your patient hearing.
Thank you, Sashi. Once again, very comprehensive talk, and I think that you also stuck to the time. So also thanks for that, because as usual, time is our enemy and we're running short of it. So I'll just like to introduce the next speaker and we'll go on. We have 2 more talks in this session. So we'll try and complete both of them before we go back to a couple of questions that we have. So next speaker is Dr. Salim Mehta. He's a consultant ophthalmologist at Leela Hospital and Research Center, Mumbai. I think it's sort of foolish to introduce him in this audience, but for all India, other people who are attending elsewhere. And Salil also has been in this field for quite a long time. He has a lot of interesting publications, especially pertaining to imaging and tuberculosis. So over to you, Salil. Yeah, hi, Salim.
Hi. So I'm not sure, how do I make this into full screen?
You go to your regular full screen button, whichever way you do it. If it's Windows, then you have, so cancel that slide thing. Yeah.
Okay.
Yeah.
So today I'm going to be talking to you about, apart from uveitis, some of the other issues that I have been facing in the last couple of years, which is drug-associated retinal toxicity. So basically, there are only 2 really common drugs that physicians use, and for which we get referrals and for which we are seeing ocular toxicity. The first one is, of course, linezolid, which is a very commonly used antibiotic for skin, bone, and mycobacterial infections. And long-term use is associated with hemat, neuro, and optic toxicity. So up till now, I've seen a lot of patients, but my basic study only involved a group of 5 patients. Now, the problem is that linezolid has been shown to be effective against drug-resistant strains of Mycobacterium TP. And it is extensively used by chest physicians to treat drug-resistant TB, and it's possibly the second-line drug for MDR TB. And it's part of their regimen, and include the Government of India regimen as well. And they use it for extended periods of time, sometimes for several months. And it, of course, linezolid works by inhibiting protein synthesis, but that's all very theoretical. All the studies of toxicity of linezolid have only been done with linezolid given for a maximum of 28 days. There is no data beyond that. But we have been using it for several months. So it's a small observational case series which I have reported. And these were all in a specialized HIV TB clinic in a 3-year period from 13 to 16. And we found 136 patients suffering from drug-resistant TB. 104 were eligible for linezolid, and 86 actually initiated linezolid. And 23 patients were referred to me at some time, and 5 of these were eventually diagnosed with presumed linezolid toxicity. So these were the 5, 3 girls and 2 boys. And apart from linezolid, of course, you can see that they're getting a lot of other drugs like capreomycin, levoflox, cycloserine, PAS. But the common factor in all of these is linezolid. So what happens is usually the visual loss is very profound. Usually the vision drops bilaterally to 660 or worse. And it improves in all the patients over a few weeks, usually within 30 to 45 days, to return to near normal. I usually treat all of these patients with oral steroids tapered over a month after taking consent of the physician. And even if they do not receive steroid treatment, they generally do well. So I will tell you, the problem in here is that our baseline testing should always include perimetry. I found that the most sensitive and specific way of diagnosing linezolid toxicity is via perimetry. So you will see, as I'll show you now, that there's a very distinct pattern of a central secocentral scotoma associated with a central bitemporal scotoma that respects the vertical midline. This is very unusual because most optic nerve diseases, the perimetric patterns do not respect the vertical midline, they respect the horizontal midline. But in this case, as I'll show you, there is a strict respect of the vertical midline, and I really don't know why. So these are the two top photographs show a patient with, when I saw them for the first time, you can see there is a mild disc hyperemia, a very subtle disc edema, and the right and the left photos at the bottom are after about 45 days, once they have received steroid treatment. You see this is subtle disc pallor, and it looks totally different. If you see the perimetric patterns here, A is the right eye and C is the left eye before starting any treatment. And you can see how there is a centrocecal scotoma that perfectly respects the vertical midline. And B and D, which is on the right side of the screen, is after 45 days of tapered steroids and obviously withholding of the linezolid. This is Rnfl thickness map. You will see how in each case there is a marked disc edema, which then gradually settles over the next 30 days. I have even done some guided progression analysis, even though I have been assured by the people from Zeiss, Cirrus, whose machine I used, okay, it is only meant for cupping and glaucoma and it should not be used for disc edema, but I have done it nevertheless. So this is another patient. You see the subtle hyperemia, subtle disc edema on the right and the left images on top. And then following 30 to 45 days of steroids, you see the resolution of the disease with a subtle pallor in both the eyes. Similar findings here. The two images on the left are showing the pre-disease images. There is again centrocecal scotoma. And on the right side, the two images show complete resolution after about 45 days. This again is the Rnfl thickness. You'll see this time that this edema is not much, it is just subtle and it drops gradually. So out of these, some 3 patients we have done MRI, which were absolutely normal. The second important drug, of course, I want to talk about, which is much more important to us, is ethambutol. Ethambutol is a bacteriostatic drug that works by disrupting arabinogalactan synthesis, whatever that may mean. Now, the big problem nowadays is that the revised National Control TB Plan insists that ethambutol should be continued beyond the first 2 months for the complete 9-month course of the treatment. So earlier we used to give INH, rifampicin, ethambutol, and pyrazinamide for 2 months, and then followed by INH and rifampicin for another 5 to 7 months, depending on the physician. Now ethambutol is part of the complete treatment. And most of the disease that we are seeing is because of this excessive use of ethambutol. So I'll give you a few ideas, a few patients who I have seen. Now, so this was a 23-year-old lady whom I have seen. Now she has undergone a routine uncomplicated laparoscopic myomectomy. Then she developed a necrotizing granulomatous inflammation along the incision plane, which evidently is quite common. So she got an anti-TB regimen of rifampicin, ethambutol, and clarithromycin. 5 months after this, she started noticing blurring and haziness in both eyes. The visual acuity was normal. Anterior segment was normal, and normal color vision as well. Normal appearance. We stopped her ethambutol, but a week later, her visual acuity had dropped to 612. So I'll show you her perimetry. You see this. It's a central bitemporal hemianopia that respects the vertical midline. This is a very, very specific finding I have seen in patients who got ethambutol toxicity. There's just a small bitemporal hemianopia that fits right in the center. And the rest of the field, of course, is involved, but not to this extent. So they will always complain that a few words in the page we can't see, but the rest of the page is clear. It's another patient who has a case of miliary TB, and she had been started on rifampicin, ethambutol, pyrazinamide, and INH. Then a few months later, with poor response, we started her on kanamycin, moxiflox, ethionomide, and clofazimine. She came with reduced vision, 660 and 6/120. See this. Again, you will see a large incomplete left homonymous hemianopia with additional defects, but see how closely it respects the vertical midline. So there's some changes going on both either at the level of the chiasm or in the level of the brain, which are not being detected on MRI. So as I told you, the RN-TCP now is suggested that we need to give ethambutol for 6 months and even more in cases of MDR. Plus, there is a new trend among physicians to use higher doses of ethambutol, up to 1200 milligrams a day, especially in DRT, because they believe that if you use higher doses, you'll get a higher MIC, and this might improve the outcomes for patients. So I have seen numerous perimetric patterns in these patients. And the commonest is, of course, central or secocentral scotomas, followed by hemianopia. Thank you.
That was a really very interesting, Salil, and something different. And I think that you really are on something new. Well, it's new now. I think you should investigate this further. We're really short of time. Padma, you want to introduce the last speaker?
Yes. I invite Dr. Soumya Basu, who's the head of Uveitis Services, LV Prasad Eye Institute Network, Hyderabad campus. Over to Dr. Basu. Unmute yourself, Dr. Basu. We are not able to hear. Can you unmute your audio, please?
Can the host unmute him, please? Okay.
So this is what hypoglycemia does to you. Sorry about that. I'm sure all of you are hypoglycemic. I'll start off with a very simple concept, how to approach a choroiditis patient for a general ophthalmologist. This is not for the retina and the uveitis experts, but when a patient comes to a general ophthalmologist, how you should approach a patient of choroiditis. So the summary is that most choroidal lesions, be it inflammatory or non-inflammatory, they appear similar, and this is quite different from what happens in retinitis. So the first thing is rule out what is not choroiditis. The second thing is look for 3 patterns of choroiditis lesions, because these 3 patterns are going to decide your treatment. The first one is there an infection? So look for signs that may suggest an infection. The second point is, if it's a non-infectious uveitis, to look for choroiditis lesions that are limited to the eye, and if it is associated with a systemic disease. So these 3 patterns have to be identified. Now, before going further, it's good to look at this schematic diagram, where you can see that the choroid is hidden behind the curtain of the RP and the retina. So you can see the pigmented RP sitting on top of the choroid and the retina sitting on top of it. So this makes most of the choroidal lesions appear similar. And it's important to remember 2 points. Firstly, choroiditis is less commonly infectious than retinitis, and pattern recognition in choroiditis is a little more difficult than in retinitis. So here are a few examples which may look like choroiditis, but they are not. You can see a lymphoma lesion here with the leopard spots on top of it. Posterior scleritis here with the surrounding subretinal fluid. Central serous chorioretinopathy with the subretinal fibrin, which is very, very commonly mistaken for choroiditis lesions. And here is a choroidal osteoma that may also look like choroiditis. Another example here. Now, this is a case. On the left side, you see a typical case of unifocal choroiditis, and you see the OCT of passing through the lesion. And on the right side, you see this lesion which may appear to you like a large choroidal granuloma. Now, interestingly, this patient had presented to a general physician with cervical lymphadenopathy about 3 months ago. And they did an FNEC, which of course was inadequate, but they found lymphocytes. And going by the general trend of any cervical lymph node being a tubercular lymph node, they just started on anti-TB therapy. When the patient came to us, and this is after 3 months of anti-TB therapy, his lymph nodes had not improved at all. In fact, they had increased in size despite the anti-TB therapy. And he was suffering progressive loss of vision for the past 1 month. And you see this large lesion sitting here. Now, once you hear the word TB somewhere and you see this kind of a lesion, the first impression that comes to your mind is that it's a tuberculoma. But his lymph nodes were not improving. The lymph nodes were only increasing in size. They were like a giant mass sitting on the right side of the neck. So that is when we got a biopsy done for the lymph nodes, and that revealed a non-Hodgkin's lymphoma. This patient received chemotherapy and the lesion disappeared completely with chemotherapy. So this is the importance of ruling out non-choroiditis lesions in a patient that appears like choroiditis. Another example here. Now, we have always been taught that if the blood vessel is passing over the lesion, then it's got to be choroiditis. So see here on the picture on the right side, you see a blood vessel passing over here. But you also see that the lesion appears very bright and there is overlying vitritis, and you see the surrounding edema around it. When you run a OCT through it, you see that the choroid is not involved. It's the retina, the full thickness of the retina that is necrosed. So you distinguish between a choroiditis and a retinitis lesion, not just on the basis of blood vessels passing over it, but also on the other features that you see in the lesion. So I guess this was the most important part that I wanted to highlight in this talk. Now we come to the 3 patterns that we talked about. One was infectious choroiditis. The second was non-infectious choroiditis limited to the eye. And the third was non-infectious choroiditis with systemic disease. Now, if you see infectious choroiditis, as I told earlier, pattern recognition is not as easy as in retinitis lesions. But if the lesion is unilateral, or it may be bilateral as well, if it is paucifocal, just a few lesions or one lesion, and the margins are irregular, and most importantly, if there is involvement of the retina and vitreous, then you should definitely rule out an infection. Now, here are a few examples. You all know that this is a typical Sapiginous-like choroiditis that is very commonly seen in tuberculosis, though not always with tuberculosis. But you see how the margins are irregular, how there are only a few foci of inflammation. So these are the signs that should immediately alert you that you are dealing with an infection. Which infection will come on later. So here is an autofluorescence picture that with the hyperautofluorescence delineates the lesion very well. The other point is about involvement of the retina and vitreous. Now, Usually, non-infectious choroiditis will not involve the retina and the vitreous. But if you see a retinal involvement, as you can see here, so the central bright part is the retinitis, and the surrounding dull kind of lesion is the choroiditis lesion. Along with that, if some of you have noticed, there is this kind of beaded appearance on the blood vessel, which is called as Chiari's arteritis. Now, this is a Toxoplasma Retinocariditis. Again, you see this lesion here. This is not as, the retinitis part is not as obvious as in the other lesion, but you see a choroidal lesion here and you see a surrounding subretinal fluid. Now, if you run an OCT through it, you see how the choroidal lesion has encroached into the retina and it is involving in the retina. And this is why you should definitely rule out an infection in such case. Now we come to non-infectious choroiditis limited to the eye. Now, non-infectious choroiditis is much more common than infection in case of choroidal involvement. This is more likely to be bilateral. It is more likely to be multifocal with regular, well-defined margins, and it is typically not associated with retinitis or vitritis. Now, those that are limited to the eye are mostly grouped under these so-called white dot syndromes. You see a couple of examples here. You see the dense opaque lesions here. This is, of course, bilateral acute posterior multifocal placoid epithelopathy or APMPP, which you see here on the left side. And on your right, you see this more faint looking outer retinal lesions that you see here, along with the foveal granularity here. Now, this is more likely to be mutes. How do you make it out? You do a fundus fluorescein angiography, and you see that unlike most of the white dots, there's an early hyperfluorescence in mutes, and then in the later stages, there is staining, which gives rise to a red-like pattern. So most of the non-infectious choroiditis limited to the eye are grouped under these white dot syndromes, and you know what these syndromes are. The non-infectious choroiditis with systemic disease, the most important disease that you want to rule out is sarcoidosis. Of course, there are several other lesions with systemic involvement, but sarcoid is the most important lesion that you want to rule out. Now, while sarcoid can give rise to a single large granuloma like you see in tuberculosis, more commonly, the sarcoid granulomas are likely to be multiple, very small, discrete lesions, typically in the inferior periphery, like you see here. You would try to look for skin lesions like the lupus pernio that you see here, or on the extremities where you are likely to see erythema nodosum. You would get a CT scan or at least an X-ray done to look for bilateral hilar lymphadenopathy. You see the potato-like appearance here, which is again signature of the lymph node involvement in sarcoidosis. So the most important non-infectious choroiditis with systemic disease that you want to rule out is sarcoid. Before we leave, don't forget the complications, and the most important complications of choroiditis are the choroidal neovascular membrane, which you see in this OCT angiogram over here. Now, how do you do a lab investigation? As I mentioned earlier, it's not easy to do a pattern recognition in choroiditis as in retinitis lesions. Now, in choroiditis, there are two important goals of lab investigations. The first one is to rule out an infection, and the two important infections that we want to rule out are TB and syphilis. And the important systemic disease that we want to rule out is sarcoidosis. So how do we do this? So for TB, the history of TB contact is important. Of course, we do a test for systemic infection with TB, which could be a MON2 with or without a quantiferon TB Gold test. Ideally, both should be done together. And imaging of the chest, of course, you investigate everything else if there is any evidence of TB elsewhere in the body. And certainly you would want to rule out everything else that is not TB. So exclude all the non-TB entities. For syphilis, the test for screening is a treponymous test, which is a TPHA or an FTA-ABS, and not screening with VDRL. If your treponymous test is positive, then only we should go ahead and do a VDRL test, because this will show you the response to treatment. For sarcoidosis, unlike what most of us do in our clinics, the way to screen for sarcoidosis is not by testing for the serum angiotensin converting enzyme, because it has a very low positive predictive value if you are routinely testing it in all patients of uveitis. So try to look for organ involvement, ask for skin lesions on the face, on the extremities, ask for a previous history of facial palsy, and of course, get a chest imaging, preferably with a CCT thorax. To summarize again, most choroidal lesions, be it inflammatory or non-inflammatory, they appear similar. So please rule out what is not choroiditis. There are three patterns that have to be identified to decide what kind of treatment you are going to do to the patient. The first one is infectious choroiditis, and here it is more likely to be unilateral, paucifocal, with irregular margins and involvement of the retina and vitreous. In non-infectious choroiditis that is limited to the eye, check for the patterns of the white dot syndromes like APMPP or MUTES. And in non-infectious choroiditis with systemic disease, the most important is sarcoidosis, to focus on the organ involvement. Thank you for your attention, and I would like to introduce you to this uveitis program that we are starting from July this year. It's a one-year virtual education program in uveitis with 12 independent modules of uveitis. You can log into any particular module or modules, or log into the entire program. There would be keynote lectures by masters. There will be special interest group meetings, international grand rounds with reputed centers across the world, and you will of course get CME credit points. Starts July 2nd this year. You can register at lbpi.docmode.org. Thank you again for your attention.
Thank you very much, Soumya. Rohit, do we have to hand over to the next session? Where, of course, we're way over time.
The next session would start at 2:30.
We have some
2:15. Rohit, 2:15.
2:15. So, Rohit, you could quickly ask the questions in the chat box.
Yeah, sure. So one of the questions which was asked was directed to Dr. Dipankar Das, was that since AC, the area is quite small in the anterior chamber, how do we go about the parasites in the anterior chamber? Surgically, how do we operate these patients?
Yeah, that's very
Any special
interesting.
precautions?
Yeah, thing is that first of all, you have to decide which site of either a temporal area will be much more access than the nasal area. Okay. Now this parasite has to be delivered very carefully, because your aim is to bring them live for future diagnosis. So by boosting a viscoat or some sort of viscoelastic thing, you can push the parasite along with the how we do the paracentesis, okay? And then the worm comes out at the corner of it, and then you deliver it. So sort of fluid you have to put in the anterior chamber to deliver them. It was same was done in our case.
Yeah. Thank you, sir. Another question for Dr. Salim Mehta is, how do we manage ethambutol toxicity apart from just stopping the drug? Is there anything else we can do?
Great question. As a general policy, I always give a course of tapering steroids to all my patients. Of course, after speaking to the physician and making sure that it is safe, I always give at least a 1 month course of tapering steroids to all my patients. There have been studies both for and against this particular practice, but my practice is to give steroids, and I found that patients improve very well. I've not had any patients except one so far who hasn't recovered at least 6/9. Most recover to 6/6 or whatever the pre-incident vision was.
Thank you, sir. And the last question is that when is the right time to do laser in patients with retinal vasculitis? Should we wait till the systemic treatment is over, or can we do the laser at the beginning of the treatment itself over the CLP areas? I believe our panelist or any of the faculty can take this. Dr. Shishir Narain, sir.
You see, we would like the retinal vasculitis to settle down a little bit. One doesn't have to wait for complete resolution, but we don't want to do it in an angry retina for 2 or 3 reasons. One is that you can exhibit the retinal vasculitis itself. There is an inflamed retina. You can cause retinal breaks. There can be retinal bleeding, because whenever it will hit an inflamed blood vessel, there's going to be bleeding. So how one would do is that if you are seeing retinal vasculitis, which is not really going to cause neovascularization within the next 1 or 2 weeks, you give high dose of steroid and maybe do the first sitting with lesser number of low intensity and with lesser number of burns. See whether a macular edema is coming in or not, and if that is not developing, then after a week or 2 weeks you can do more sessions with lesser number of burns in one go. That's how I would treat. I mean, it would be nice to know how Salil and Somashila would also manage the retinal vasculitis with laser. But that's how I would do. I would not do it unless I know that it's going to have a neovascularization within a week or so. Having said that, the patient that I showed you with candle wax stripping, within a week he developed neovascularization of the disc.
Thank you. I think that, Rohit, we should conclude the session. So I would like to first of all thank BOA for having the session, BOA and MOS, the combined meeting. And of course, all our speakers spoke so well, and we had the luxury of extra time. So we slacked on the discipline of sticking to the time in interest of listening to such wonderful talks by just about all our speakers. It was a real treat for me, at least, to be part of this session. And thanks to all the speakers, and thanks to the audience, if there are any remaining who are still listening to us. And thanks once again, Rohit, Preetham, Dr. Lani sir, and Dr. Ragini for giving us this opportunity for this session. So with that, we conclude the session.
Thank you. Thank you.
Thank you.
Thank you. Hi, thank you. Hi to the next group of people there. I can see Dr. JB and Rima. Hi. So that's the advantage of being in a meeting. You can say hi in the intervening period unless your session is already starting. Hi, Amitabh. How are you?
Dr. Sashir, I'm fine. Thank you.
Yeah, we are not going to boot out because we are going to be listening to you.
Yeah, sure.
Thank you, Shishir.
Hi, how are you, sir?
Hello, sir.
Hello, how are you, Dipankar?
Hello, sir.
Fine, sir. Thank you. How are you?
Fine, thank you. Thank you very much. What time the next session starts? 2:15 or 2:30?
2:15.
2:15, no?